And once again, I am very excited to be featuring Dr. Falconer today from the Inova uh, Parkinson's and Movement Disorder Center. And I think I've said it on other occasions, but the first time I had Dr. Falconer on, he was talking about essential tremor. And I realized that my mom and my cousin both have a significant essential tremor. And when I reached out to my mom, she was resistant at first because she talked to a doctor, I think 20 or 30 years ago, who told her there was nothing she could do. And but I encouraged her to see Dr. Falconer, and it has absolutely changed her life. And it's absolutely changed my cousin's life too. And I'm just absolutely amazed at what Dr. Falconer was able to do with the modern treatment for Parkinson's and essential tremor. And so I'm always excited to have Dr. Falconer and other healthcare providers on to keep us up to date on what's going on in their practice, because a lot of us, you get a diagnosis many years ago and you just learn to live with it. And if you're not on top of this stuff, you could be minimizing the lifestyle that you could be living. So I know I'm babbling now, so it's time to get you talking there, Dr. Falconer. First off, for those that are tuning in that have not met you, give us a little bit of your background and what led you to your current position at Inova.
Sure thing. And thanks again, Steve, for letting me be part of this community and this kind of engagement. This is always really fun for me to do because you think that we spend our days talking about all this, but I always feel like we don't talk about it enough. So having a platform where we can continue to educate and hopefully dispel some of the misnomers about what we do is always, always a blessing. So for those that don't know, my name is Drew Falconer. I am the director of the Movement Disorder Center, Parkinson's and Movement Center here at lovely Inova Health System in Northern Virginia. In terms of my background, I am from Louisiana originally. So if you ever want to talk food, I'm always game for that. If on a Saturday you ever want to just lounge back and watch some college football, always game for that as well. But I did my medical school in Louisiana and then came up to DC to attend residency at Georgetown. And that's how I ended up in the Northern Virginia area. And during my medical education down in Louisiana, it was one of those great moments where you have no idea what you're going to do with your life and everybody's pushing you to figure it out, right? You've kind of reached that inflection point of student loans, work, and education where they're like, okay, what do you actually want to do with all this? And I had the privilege, this was a lot longer ago than I tend to admit, but I had the privilege of seeing a deep brain stimulation procedure way back in medical school when it was a brand new thing. The attending was like, come see it. This is something that's new. It's a real cool opportunity. So I go down to the operating room at Ochsner Hospital in New Orleans, and there is a gentleman with Parkinson's disease that was so profound that the whole table was shaking because his tremor was so bad. They put the DBS in his brain, they turned it on, and it was like a switch went off, and he just calmed down and stopped shaking at all. And I'm like the young, impressionable medical student. I think, holy cow, that is the coolest thing I have ever seen in my life. I want to do that for the rest of my life. And so that was it. And so I went into neurology with the intent on being a movement specialist so that I could do DBS, which we do. But then in the process, really discovered what's so cool about our specialty. And that is the fact that most people are touched by Parkinson's or a movement disorder or essential tremor, right? We can all pick somebody we know of, that our cousin, our mother, our uncle, the guy down the street, the person who sits 3 pews in front of me at the church and they have to bring communion to them, right? We all know Parkinson's. We all know these disorders that I'm now a specialist in, but we all have kind of a skewed view of what's possible and what it means to have these conditions because of what we think we know, right? And what's fun about what I do, and this is what we do in clinic every day, which is why we really have a good time here, We take folks who come to us with all of this baked in preconceptions about what it means to have Parkinson's tremor on down. We take all these baked in preconceptions about what the internet said and what the great old wives' tales have passed down to us, and we get to break that down. Because in reality, how we treat, especially Parkinson's disease today, is vastly different than how we did even 15 years ago. And it's not that the condition has changed. There's nothing fundamentally different about Parkinson's from 1965 to today, right? No, the fundamental difference is how we think about how people's lives are during the day with Parkinson's and the tools that we have that we can employ to fix things. I mean, it's no secret in the world of Parkinson's, we've had 13 medicines come out in the last 5 years alone. And these all represent better, more focused, more intense, more intended therapies that go to fix things that are holding people back every day. But the real unfortunate truth is that not only do the vast majority of patients with movement disorders not see a specialist like me, but the vast majority of patients, even the ones who see specialists, haven't touched medicines that have been created in the last 30 years. So if you take the world of Parkinson's, and I do a lot of talks for patient groups, I love engaging with people because that's how we make people better. I can't tell you how many places I go and I ask, who's taking carbidopa levodopa? Everybody raises their hand. And I say, who's taking something that's not carbidopa levodopa? And all the hands go down. That's crazy. It's accepting good enough that a medicine that was created 50 years ago is the best we can do. The honest truth is, if that's the best we can do, I give up, right? That's ludicrous. We, every day in clinic, all we do is take folks who are afraid because they think this is the best it can get, and we just update them. We say, no, tell me what it is that's keeping you from going out there, living life, and doing what you want to do. What is it that at 4 o'clock is holding you back? Let's talk about your life. And then we use the tools that we have, the right tools for the right job, to get people back doing what they love. And there's no greater joy that I can tell than having somebody come back to clinic where they had accepted they couldn't do something, right? They accepted it as, this is it. I'm 65 and it's going to be terrible, right? And then they come back and they realize that that was all just like self-propped walls that weren't real. And we treat them better, we update them, we get them integrated with the community that is what we do. They come back and they're like, holy cow, you were right. I can go to Zoom at 4 o'clock. I feel great.
Yeah.
Right.
And my mom is able to carry a hot coffee pot or cup of soup across a room, which she couldn't do. And my cousin can dial a phone now without bracing his hand. These are things that you come up with a workaround, and you don't need that workaround. Now, on one of our previous discussions, I know this was kind of tongue in cheek, but you said something.
I live my life in tongue in cheek. So
yeah. So, but I thought it was. I've quoted you, and because I've done it so many times, I want to check in with you on what you mean by this. But it's very powerful. At least it impacted me. You said, in 5 years, I might be treating people's back problems because we are going to solve the problem of Parkinson's. Can you elaborate on that?
Yeah. So what's exciting about what we do is that the level of engagement in fundamental research, in therapies, in approaches to Parkinson's revolutionized. Over 15 years, we've reinvented how we treat this disorder. And every year we get new therapies, we get better therapies. We're averaging 2 or 3 new medicines every single year. That's crazy. That's a cadence and a clip of development, which is unheard of, right? But it all serves you better as in the community, because it's just better tools to fix the problem that's there, right? It's really, I tell our medical students what we do every day is not really all that complex. We spend our time talking about our lives and our families and get to be friends. And then we just take it from 1985 to 2022 and magically people do better. But underneath all of that is just how close we've come to actually fixing the trajectory, the fundamental problem at the root of Parkinson's. Because we can treat this symptomatically extremely well, but we don't have a tool we can employ to slow it down or stop it. And we're almost there. And remember, there's 500 studies in the world going on to try to fix that. We just need one to hit. We don't need 500. We just need one. And that's that message of hope.
Now, I know that there's people in the audience who have loved ones with other disabilities and diseases and things of that nature. Reflecting on your knowledge of this rapid progression in your segment, is there one or many things that you could identify that sort of has given birth to this rapid development of drugs and treatment?
If I jokingly said that we have a spaceship somewhere that we're slowly taking technology off of, would that make sense? That's a joke. No, honest truth. It's just that we as a society of researchers have realized over the last probably 20 years that there are a lot of people with Parkinson's disease. I mean, we're dealing with over 1 million people in the US alone, estimated that by 2030, it's gonna be 1.5 million people in the US with Parkinson's disease. That's a ton of people, right? And so the science, the industry side, the pharma side, all these things have come together to try to develop therapeutics for that. Because at the end of the day, we got to make people better. And for 40 years, we just sat back on, hey, we invented this in the 50s, works great. Let's just keep using it, right? Okay. Not realizing that every great tool, no matter what it is, has limitations. Mm-hmm. And so I think it's finally reached a point of development in the pharma side of the world where we can start to do things therapeutically that we couldn't 30 years ago because the technology to do it wasn't there. And all along, we're just understanding the fundamentals of this condition better and then developing tailored ways to try to address it.
Great. Well, this is exciting, and it gives us hope for some of the things like Alzheimer's and dementia and other things. And I think also the way that the medical community and the pharmaceutical community has rapidly discovered solutions with COVID only means more rapid development with other disorders as well.
You got it. In the messages, no matter what you got, be it Parkinson's, neuropathy, back pain, migraine, epilepsy, if you name a condition in neurology, because neurology affects everything, like anything that touches the nervous system is neurology. I'm just a specialist in one area of it. But the message is, don't feel like you're ever at a point where that's it. Things are constantly evolving. Things are constantly changing. We're constantly getting better tools to address problems across the board. So constantly push, educate, never feel complacent that you don't want to take that self-advocacy moment to really try. And if you start to hit a point with any physician, and this is just me being a doc and saying it because I care, but if you ever feel like you're in a place where you're getting a bad deal, where you just kind of get brushed off, and I mean, we all know that we're humans, right? And you feel like that you bring up the idea of trying things and you're dismissed. There is nothing wrong with a second opinion. You will never hurt anyone's feelings. If you feel like you did hurt someone's feelings, that's further validation that they shouldn't be your physician, right? Because at the end of the day, our job should be to make you better. And if you're choosing to not do things because of your neurologic problem, and someone tells you, suck it up, and come back in 6 months, that's when you need to find somebody else. Because I promise, we see people all the time. Look, 20% of our patients who see us are actually misdiagnosed to begin with. And then beyond that, once you start to rob people of hope, you start to rob people of the joy of living. And that's not fair. That's just not how medicine should be. That's not how I'd want my parents treated. I wake up every day thinking, okay, every person I'm seeing is someone's mother, sister, brother. If my grandmother or my mother went into a doctor's office, what level of care, how would I expect her to be treated? And I lead with that, and I lead with grace. And a lot of people don't,
All right. Well, this has been a great warm up, and all it's done is pile up the questions. And Dr. Falconer, you're so good at for most of these, I read the questions to people, but you're pretty good at doing this. I'm happy to choose these or read these, but if you want to attack them, we've got Hanaya and Mary and Mamela in the Q&A,
Look at
and
that.
then we've got a few in the comments there. You tell me what the best approach is today.
Um, Steve, I love living in Northern Virginia. The trees are beautiful. The azaleas are lovely. But the trade-off is I'm from Louisiana and my allergies don't agree. So if you could read them, it would save my voice just
absolutely.
because I am getting blasted by allergies right now. That's why I keep drinking my giant jug of water.
Yeah, I'm about a week away from that. So yeah, let me attack this and just be patient. Some of these questions are a little bit longer, but
That's
Hanaya, and I know I'm botching your name, says my mom is 82 years old. She switched to Ritalin a few days ago. I was instructed to give her 2 pills every 6 hours, 3 times a day. Since she doesn't start her day till 10, so we did 10, 3, and 9. She couldn't fall asleep, so I gave her melatonin at 10, and she kept taking it a while, lie down, get her eyes closed. She doesn't do a lot of movement during the day. What do you recommend? Planning to share this with her doctor as well.
So I will answer that in the form of a generalized what if. And I say that for the regulators who are listening to the Tory conversation, because in these kind of forums, we can't directly treat people. It's a little bit of a weird regulatory gray area because we all do telehealth now, and we don't want it to be a telehealth type exchange of info, because then if you're not in the state of Virginia, it's needlessly bureaucratic. But I will say, in theory, if this were a hypothetical patient, I think step 1 is to realize why you're changing to Rytari, understand the reasoning behind it, and then yes, try to find both the dose that that person needs as well as the appropriate interval. Because at a very fundamental level, Parkinson's disease is just a chemical deficiency. It is just a deficiency of the hormone dopamine. So when the tank is low, you get symptoms. If the tank is properly filled, you do better. And the problem with classic carbidopa-levodopa, the original medicine from 1972, is that it's a great medicine. Levodopa gives dopamine back, but it doesn't last very long. And it's not a flat not last very long. It shoots up in your system for about 90 minutes, drops like a stone over 3 to 4 hours. So if somebody has a deficiency all the time, Parkinson's disease, then over time, just using classic carbidopa is incredibly limiting, because they start to feel it work, feel it go away, feel it work, feel it go away. And those fluctuations during the day are not Parkinson's disease fluctuating, they're the medicine fluctuating. It's really a medicine problem, a consistency problem, not a Parkinson's problem. So we tend to use Rytari a lot because Rytari is a longer lasting, better delivery system for carbidopa-levodopa. Instead of 3 to 4 hours up and down, it should give you 5 to 6 hours of smoother, and it's actually detectable in the blood up to 10 hours later. With any of these medicines, the 2 variables we can control is, number 1, is the dose enough? Is it making you feel better? And number 2, is that feeling better lasting between doses? And so if she's not starting her day until 10 a.m., it's fine to start it at 10 a.m. But I tend to tell folks you want to take it right when you wake up in the morning, whenever she wakes up, because if you think about it, she's then going from 9 p.m. until 10 a.m. the next morning with nothing, which is what, 13 hours? It's a long time. So starting right when you wake up tends to work best. And Rytari actually works best at about a 5-hour interval. Some people can get away with 6, but most people need it every 5 hours. And so if you can, people tend to do their absolute best 4 times a day, 5 hours apart, because then that gives you a dose at bedtime to help with sleep. Now, and that could be why she's having sleep issues too. You're asking her body to go from 9 p.m. until 10 a.m. That means that overnight her tank is running low, which makes most people wake up. So there are a lot of different ways to approach this kind of a case, but I will tell you that if she just switched to Rytari, be sure to communicate with your doctor within the next few days with how she's doing. The vast majority of people on Rytari, we have to tune the dose within the first week to really get it to be in a good spot.
Great. And that sort of ties in with her second question, which does magnesium help with anxiety caused by PD medicine? And it sounds like she's in a phase right now where there's this fine tuning.
Yes.
So communicating that anxiety to the physician is very important too.
Yes, because dopamine is a feel-good, happy hormone. It shouldn't make you anxious. It should actually make you feel better. People on the older Cinemet tend to feel anxious because it's whipping in and out of their system a lot. Rytari tends to do a lot better with that. But if anxiety is still a problem, that could be wearing off. That could be periods, gaps between her Rytari, which we can just medicate better. Or it could just be good old-fashioned anxiety, which comes along with having, being human.
Is magnesium a treatment that you use for anxiety sometimes?
Yeah, okay. Sometimes it's a good over-the-counter supplement for it. Some people will use CBD, but that's kind of like the greatest snake oil of our generation. Honestly, anxiety, it's just so multifaceted. Exercise in and of itself helps. Going outside, breathing some fresh air helps. There's so many ways we approach it because it's so different for everybody.
Yep. Okay. Mary Busey says, my friend has been diagnosed recently with Parkinson's Lewy body disease. I'm unable to find very much helpful information on the web. Do you have any helpful advice for her family? Well, Mary, the good thing is you tuned into this discussion and we're taping it. So you're going to be able to share this recording with her, which I think is going to be a great resource for this family. But Dr. Falconer, what advice would you give to this newly diagnosed individual?
Yeah, biggest piece of advice, 2 parts. Number 1, take a deep breath, realize you're going to be okay. And second part, you need a movement disorder team to be part of your team. In the world of neurology, don't forget that general neurologists are wonderful. They're fantastic. I love them all. We have a huge community here in Northern Virginia that we work with of general neurologists. But they're jacks of all trade or Janes of all trade. They are not specialists in Parkinson's and movement disorders. In the world of medicine, you go to your internist and they take care of you. They do a great job. But if something comes up that requires specialty care, you have a stomach issue, you have a cardiac issue, you have, God forbid, they tell you have cancer, you will then go to a specialist in cardiology, GI, cancer, right? Well, don't forget all of those specialists, cardiology, GI, hematology, allergy, oncology, they're all internists. They're all general practice doctors who then did specialty training in a specialty area. The same is true in neurology. General neurologists are fantastic and tend to be good jacks of all trade. And I don't know how they manage everything because it's a lot. But then there are specialists in movement disorders and epilepsy and multiple sclerosis and headache, you name it. Again, biggest piece of advice is with something like Parkinson's disease and Lewy body disease, you need somebody like me to be part of the team. The statistics bear out that people don't do that. Only about 20% of patients with Parkinson's will see a specialist like me. And once you're talking about cognitive issues like Lewy body dementia, which is part of, in some people's case, Parkinson's disease, you're really dealing then with 2 sets of symptoms that fight against each other. So we have cognitive issues, and one of the hallmarks tends to be delusions and hallucinations, and movement issues, which is Parkinson's. And it really takes a specialist to be the captain of that ship because we have to treat both. We got to get them moving better while making all the cognitive stuff better too. And if you don't do it right, people either ignore one or the other, or the medicines we choose tend to battle against the other side. So it really takes a higher level of specialty to get it right.
Great. Okay. We got a few questions on the cost of medications.
Great question.
Holly says, do you have recommendations on covering the cost of Rytari? I have a client who's paying $428 a month. And Mamela says, are there new medications in the market that are covered by Medicare? I imagine both of those questions are going hand in hand.
Yes, and it is a very direct answer, and I'm glad you asked it because we hear it all the time. Remember, there is no Medicare for drug cost, right? Everybody's got a Part D plan that's managed through somebody else that you choose. So there is no unifying Medicare plan that everybody is covered under. Every person picks a plan that has a formulary associated with that plan, that has a cost list associated with that plan, that has deductibles and all this other complexity of insurance that is your specific plan. So realize then that you can get a different cost for every medicine, no matter who you are, where you are, what you do. Rytari, for instance, if I show up with cash, no insurance, to the CVS, Walgreens, Costco, you name it, I'm going to get a different price at every one, right? If I show up with insurance, it's going to be a different price depending on what my insurance is. And it's going to be a different price during what time of the year it is, depending on my deductible for my drugs, right? And that doesn't even take into account mail order, where then you could magically send it to CVS Caremark. And if your plan approves it, it's cheap. So there really is no such thing as medication cost. And I think I want to make that very clear. And I know that it's a cost issue. Hear me out. There's really not a cost associated with these drugs. There's a coverage associated with these drugs. And so we have to think about drug cost as an insurance coverage problem. So if you go to the pharmacy for Rytari, let's say, and you fill it, and it's $30 a month, you won the insurance lottery. Good for you. Let's just live life and go for it. If you go to the pharmacy and it's $1,000 for Rytari, first off, don't pay it. Whatever you do, don't pay it. Talk to your doctor and tell them that, because it's not really that the CVS is picking on you. It's just that your insurance is not covering it well. And that's true of every name branded drug that there is. And there's no way for us to check ahead of time. That's the best part. They don't give us the ability to know, right? So how we do it best is, first off, we talk about you. We talk about your day and your issues and how we need to make you live better with whatever you got. Then we have to make a logical plan on using a therapy to do that, right? We make the decision on what to try based on the plan, not the cost, because there's no way to tell the cost. Then what I tell folks is we send the prescription in and we realize it's a game. It's all a game. It's a stupid game. It's insane. I promise. We send in the prescription to your local, Walgreens, and you call and ask about your copay. And if your copay is good, we're good. But if it's expensive, you don't pay it. You message me and say, you were right. They told me it would be $1,000. That's crazy. And I reply back and say, yep, that's crazy. So what we need to do is ask your insurance to cover it, right? It's a game. And the nice part is all of these name branded drugs have a program that's run by the companies to help with this. I mean, they're incentivized for you to be on drug, if you could imagine, because that's their business, right? So we're picking on Rytari, but Rytari, for instance, has a program called My Rytari, where we sign you up for it. They give you a case manager who you get to know because it's the same person every time. And they call your insurance, fight them, and bring down the cost. They send you free drugs. They send you a lot of free samples in the mail. And they will actually check in on you throughout the year to make sure it's still well covered. And if there's still a copay issue, even if $50 is too much, they will have a whole list of foundations that help with copay support. But guess what? Most people will go to the pharmacy, here $1,000, and never go back. When in reality, if that's a limit, then it's probably a limit of all the new drugs, because that's how your insurance is built. But if we view it as a game and that we want to get you there for a good scientific reason, then we just play the game and magically it gets better. I can't tell you how many people, again, we'll pick on Rytari, that they'll go to the pharmacy and it's like $1,000 a month, which is ludicrous. I fill out 1-page form, sign it, and magically it's $30 a month. Like, it's so stupid, right? It's a game, but you got to know it's a game to not give up.
Well, and this speaks to the value of your practice and being engaged in a practice with practitioners. It also speaks to my friend, Dr. Dappin, who started a medical practice called Doc Talker, because when he started practicing medicine, he realized you needed 4 staff members for every doctor in the practice. And this is a shining example. To play this game, you need a team. And you got to
be accessible. You got to communicate.
Yep.
And so I think that's also one of those red flags for patients, that if you go to your doctor and say, I want to try this new thing because I'm not doing well, and they say, no, it's all expensive, that's a sign to find somebody else. And if you go to a doc and you say, oh, but it's so expensive, and they say, they're all expensive, pay it or try the old stuff. Again, that's
find
not
a new
partner.
doctor. Yep.
Yeah, Because if the best we could do is what the insurance wants, which is a medicine from the Nixon administration, literally 50 years old, good luck, right?
Yep.
So we fight for
All right. Okay, Rosalind says, what techniques help dyskinesia? And for somebody like me, can you briefly define what dyskinesia is?
So dyskinesia is hyperkinetic movement associated with some people's Parkinson's. So it's what we all think about with Michael J. Fox, right? Michael J. Fox wiggles and moves all over the place and is uncontrolled. That's actually not a symptom of Parkinson's disease. Wild, right? Everybody thinks it is, but it isn't. If you have someone with Parkinson's and they're not treated, they will never be dyskinetic. In fact, dyskinesia by definition is the opposite of Parkinson's disease. With Parkinson's, everything is constrained and quiet and slowed. It's like the person's bubble and their world is just closing in. Dyskinesia is the opposite. It's too much. It's excessive movement. Dyskinesia is a side effect of our medication. So what dyskinesia represents is if we're treating you and you're underdosed and we give you medicine to make you full, right? It's a tank, it's a chemical deficiency. So we filled up the tank, then dyskinesia is when you've overshot it and have become toxic or super therapeutic. It's you're filling the gas tank and the gas sprays back at you. Then for a lot of people on classic carbidopa levodopa, we have to entertain some dyskinesia because it's a mountain, right? It goes up and down, and the widest part of the mountain is at the bottom, right? So if somebody's on a low dose, they feel good, but it doesn't last very long. And so we make it last longer by going up on the dose, right? Then the wider part moves up, but it's a mountain. So then the peak gets higher and you get dyskinesia. Again, dyskinesia is a product of the best we used to be able to do. We have fantastic medicine that makes it stop. Gocovri is a great medicine. You add it at bedtime and it works on dyskinesia as well as off time once a day. But all we do is think about it as a chemical problem and trying to smooth out your medicine. And by going to better, newer medicine, people don't really have dyskinesia anymore. I mean, we have all of the last 13 medicines, the primary outcome was off time reduction or on time improvement without dyskinesia, and they all get better.
Right. And Rosalind has another question, which is what can help vagus nerve damage that causes acute GI issues?
Ooh, that's a good question. That's hard. It's a hard answer because we need to have a GI doctor be part of your team. Very important that you have a neurologist and a GI doctor. And the real challenge is we're dealing with damage. So damaging a nerve, be it neuropathy, spinal issues, you name it, damage is hard to repair because it's a physical structural problem. And so there's not really all that much that I know of from neurology that we can do to help a damaged vagus nerve work better. But yeah, talk to GI as well. I don't even think we can do vagus nerve stimulation, but I don't know if that would actually impact a damaged vagus nerve.
Okay. Yeah. But again, you are in communication with the GI specialist and, helping.
Got to be a team. Got to be a collaborative team.
Okay. This is I think we can do two of these questions at once here. One is from Karen and one is from Jill. Karen says, please comment on treatments that now best address PD-related emotional and cognitive issues. And then Jill says, the best meds or therapy to research for essential tremors gets worse with stress and anxiety, impacts getting ready in the morning, playing piano, writing, sleeping, and the left side is worse.
Yeah. So the emotional issues of Parkinson's and all neurologic disorders, we need to make sure that we know the cause, right? Very often we get comfortable with labeling a symptom the cause, and that doesn't actually do us a lot of service because we need to identify the cause of said symptom. So if the emotionality is coming from depression and anxiety, we need to treat it, right? If the emotionality is coming from the medicines fluctuating, we need to give you better, more consistent medicine. And if the emotionality is coming from something called pseudobulbar affect, PBA, we have to identify it and treat it. Now, PBA is a condition, a symptom of all neurologic disorders, and it is marked by emotional lability, variability, and emotionality that's not consistent with the stimuli. So it's not someone who cries when they're depressed, it's someone who cries at the drop of a hat or becomes very emotional in a very mild stimuli. There's a disconnect between mood and affect or how you're presenting that emotion. There's actually a fantastic treatment for PBA. It's a medicine called Nudexta. And when you take it and you have pseudobulbar affect, that emotional lability, it tends to make 80% of people go into full remission and get better. And the remaining people see a significant reduction in their issues. So, and identifying the cause of the symptom is step one. Now, cognitive is a whole different set of kettle of fish, but emotionality, depression, and anxiety is a great mimicker of cognitive issues. We always used to call depression pseudo-dementia, because with depression, anxiety, and you have difficulties with focus and motivation, which in many ways looks like dementia, but it isn't. So again, find the cause, come up with a plan to treat it, because there are plans and treatments that we have. Now, essential tremor is a whole different thing. Essential tremor is not Parkinson's disease, remember that. And you will not necessarily get Parkinson's if you have essential tremor. Essential tremor is not a dopamine deficiency. Essential tremor is a problem with the very back part of the brain, a part called the cerebellum. Your cerebellum with essential tremor was not developed the best. The midline part is a little bit off, and it tends to run in families. So essential tremor is a tremor that tends to come out with activity. The reason why that tremor comes with activity is because your cerebellum is the coordinating, targeting center of the brain. You go to reach for something, when you go to pick up something, you're eating, you're holding a cup. Someone mentioned playing piano. This is all movement that relies on the cerebellum to coordinate. And the cerebellum, the phase is a little off. So instead of being smooth, it shakes, right? Well, because it's a different part of the brain, because it's a structural issue that is sending out an abnormal electrical issue, we treat it very differently. So there are 3 good medicines that we tend to use for essential tremor, and we can use them in combination. There is also the beauty of deep brain stimulation, which makes essential tremor completely gone or 90% or better suppressed forever. Works great. There are also a bunch of new therapies coming out for essential tremor as well. We're a clinical site for 2 of the new therapies that are targeted for essential tremor. We will be enrolling starting here in a few weeks. So if anybody with essential tremor wants to enroll in the future of essential tremor care, we're looking for folks with essential tremor too.
Wow, that's exciting, and hope that helped Jill. Okay, Kathy Glazier says there's a connection to itchy skin, scalp. Do you have any info on this?
Yes. So your skin is the biggest organ in your body. Don't forget that. And actually, on an embryologic level, when you're being developed and you're little bitty in a womb, the origin of the basal ganglia, the substantia nigra, the place where Parkinson's comes from, is actually the same embryologic origin as your skin. Crazy, right? So they're connected all the way back when you were just formed in utero. In fact, that's why the substantia nigra, the part of the brain that is going away in Parkinson's, is called the substantia nigra. When we look at it on pathology, when we do an autopsy, the substantia nigra are 2 little black strips on the base of the brain. That's why it was called the substantia nigra, because it's filled with black substance, substantia nigra, right? Well, the black substance is actually melanin, or the same pigment that's in our skin, because they all come from the same embryologic origin. So our skin is susceptible to the effects of Parkinson's disease, just like the rest of our bodies and our brain. And in fact, in Parkinson's, people tend to have either really dry, flaky, itchy skin, or they tend to produce too much oil and they feel they're kind of greasy, slick, the other end. Tends to not be in the middle. The dry side of the equation, dry skin, itchy scalp, is a tough one. A lot of people have issues with that. And there's also a higher risk of something called seborrheic dermatitis, which causes those symptoms in Parkinson's too. As a neurologist, I can't tell you how to treat it other than moisturizing lotion. But I do, if there's any skin issues, having a dermatologist be part of our team is measurably helpful and people do better. Long way of saying go see a dermatologist too.
All right. Okay, we got a pile of questions. We got about 15 minutes, but we can get through them here.
We can rapid fire.
Lori says, is it best to wait as long as possible to stay off levodopa type drugs? Does it wear off faster the earlier you start? And does it reduce or get rid of tremors, fatigue, or insomnia?
Great question. So we don't delay therapy. We don't choose not to use things when we need to. The old approach of limiting levodopa and limiting therapies was not based on the medicine. It was based on not having options. right? If we had an old agent that after 5 or 6 years, people felt the fluctuations, we didn't want to use that until later on, right? But now we have 23 medicines that we can employ to make this better. So we need to treat you with the best medicines we have today. And levodopa is the foundational therapy for most people because it's the only way to give you dopamine back, right? So we tend to go to levodopa pretty quickly. And over time, remember, people, it does not stop working. There's this old misnomer that the medicine only has a shelf life of 5 to 6 years and then it doesn't work, blah, blah, blah. It's absolutely not true. All that happens is after 5 or 6 years, you start feeling the medicine fluctuate, which it was doing that all along. You just were able to compensate up until that point. So it always works. We just start to feel its limits over time. And when we start to feel its limits, the medicine, we just put you on better medicine and people do better. So we don't tend to wait on levodopa anymore. Is that the only question?
Oh no, we got a few more here. Let's see. Sig has Sig. I saw you put this in comments, but I'm glad you put it in Q&A. Have you treated persons with Parkinson's who also have vascular 3PD, persistent postural perceptual dizziness?
Yeah, we have. I mean, the postural symptoms, postural hypotension, postural dizziness can be a component of the cardiovascular effects of Parkinson's disease. But if there's a vascular component, like he had suggested, yeah, you can have vascular injury or insult that affects dizziness. It usually isn't postural, though. Usually if you have a structural problem, if you've had a stroke, that's the vascular side. It tends to be there all the time because it represents permanence of injury. But it's just that it becomes a part of the story of you, and it becomes a part of all the different issues that are going into your daily functioning that we need to address. That's why we tend to talk about how people are doing and how their day is instead of going through questionnaires and doing UPDRS scores, because I don't really care what I think you need to do. I need to figure out what are all the parts that are holding you back and how do we address that.
That's great. Sally Ann says, is there a connection between Parkinson's, Lewy body, mild cognitive changes, and neuropathy? What do you think about the Exelon patch?
Yeah, Exelon Patch is great. That's our first go-to for cognitive issues in Parkinson's disease. It's the old trade name. The generic was rivastigmine, which is what we use now. It's much better than the pill. The pill version tends to give GI issues to most people. So that's why we use the patch. Plus, it's a patch, so it's smooth, consistent, predictable. In fact, the rivastigmine patch is the only FDA-approved treatment for Parkinson's and Lewy body dementia. So we tend to use it. Works really well. All those different issues she described are all separate, but also associated. That's the hard part. None of us just pick one thing or read the textbook and have one very obvious thing. We're all humans living life with all these different issues battling around. And unless you take the total picture, you might miss an opportunity to help people.
Great. Let's see. Roderick says, focused ultrasound treatment of my essential treatment resulted in additional tremors. Is this unusual?
Being that this is a recorded line, I will say that focused ultrasound should not make your tremor worse. But any advice beyond that, I don't want to dabble in for all the medical legal reasons you can say. What I will say on a grander scale is that we tend to be as a community of specialists, we are hesitant to recommend focused ultrasound as a treatment. It's been an option for 5 years now. We've done none of them through our center because all we're doing with focused ultrasound is using the combination of ultrasound waves to create injury to the brain. It's creating a lesion. It's affecting an electrical pathway that's firing abnormally that we then block by burning a hole in the brain. Well, that's permanence of injury. And if you hit the wrong spot, other things happen that are bad, that are permanent. You can also only do one side of the body because there's such a high risk of damaging something that they don't let us do it on both. And we have DBS, deep brain stimulation, blocks those electrical pathways with energy in a way that we can reverse, in a way that's adaptable and programmable. So the tremor worsens, we adapt how the device is signaling and it goes away. So 10 out of 10 times we do DBS because it gives us a tool we can use forever. So focused ultrasound is a little controversial in our world about where to use it and how.
Okay. Looks like we've got about 3 questions. Sally Ann's got her hand raised. I'm going to allow her to talk, although I think I did read one of her questions. Rosalind says, what about gene therapy when there's physical structure damage
Gene therapy.
as vagus nerve damage?
Well, and that comes up in Parkinson's all the time too. Don't forget, gene therapy sounds awesome. It sounds like the thing that can fix everything because it's kind of taken on its own life in our social vernacular. But in reality, it's really hard to do. The premise of gene therapy is there's a gene that's broke. We're going to go in and change it to fix it. And there's no gene therapy I can think of that can fix something that was damaged. So if you have a stroke, if you have nerve injury, it's not really a gene being broken, right? It's the structure being broken. So there's not really a gene that can flip on to help it. No, we also get a lot of questions about stem cells, right? Stem cells sound like the fix for everything. Oh, we have a part of the brain that's not producing dopamine. Let's put some stem cells in there to regrow it and make it better. Well, that's insanely hard to do. Don't forget, if we have a progenitor stem cell and we put it somewhere and it grows into what we want, then hallelujah. If it grows into something we don't, that's called a tumor, right? And so we've had countless stem cell studies fail miserably in our world because they ended up just giving people tumors. And so don't go fly somewhere and pay $1,000 for stem cell treatments or gene therapy because none of it's really proven right now.
Okay, great.
PSA.
Okay, 2 more questions here. Does having a pacemaker rule out treatment with DBS or essential tremors?
Nope. Still good. We have a number of patients that they have because a pacemaker runs the heart and is actually the same platform, very similar as the DBS platform. In fact, when Medtronic was the company that first invented deep brain stimulation, and at the time they were the world leader in pacemakers, and they just took their pacemaker and repurposed it to run the brain instead of the heart. We have any number of patients that have a DBS on one side and a pacemaker on the other.
All right. And our last question, and it looks like it's perfect timing, is Riva
Yes.
Stigmine the same as Aricept?
No. So Aricept is donepezil, which is a pill you take at bedtime to help boost that circuit of memory in the brain. Works relatively well. We tend to more use that in the world of Alzheimer's dementia. Rivastigmine is Exelon, which is that patch we were talking about it, that is more intended for use in the Parkinson's world. So we tend to use rivastigmine in Parkinson's and Aricept or donepezil in the other dementias.
All right, and I see Sally Ann has her mic open now. So Sally Ann, any additional questions? And then we can close things out with Dr. Falconer.
Yes, I wanted to thank you both. This was a terrific discussion, very helpful. And I wanted to ask Dr. Falconer if you could please tell us about the center that you're involved with and what a new patient would have entry into. What would that process look like?
That's
Wow.
That's like the setup for the closeout there. So
Yeah, thank you, Sally Ann. This is great. Okay.
you put it up to the rim. I'm just going to dunk it through. How about that? Oh my gosh. So in the world of Parkinson's disease, you will find practitioners who love Parkinson's who work in a solo setting by themselves. And then you have centers like ours. So we are a Parkinson's center in every respect. We have, I think on a yearly basis, see about 4,000 patients with Parkinson's disease. We implant anywhere from 35 to 40 deep brain stimulators a year. And we have now, we just hired our 5th movement specialist who 5 days a week, all we do is treat Parkinson's disease. And that's what's important is you have a center like ours be part of your life because we really view you as the center of that wheel and all the spokes around it are there to support you. And we're just a really important component of that wheel. And we have to be able to talk to the rest of the wheel to get you running. So if you come see us, the very first visit, we just go through how you got to this point. A good Cliff Notes history of life, love in the last 10, 15 years of your life. We figure out then the treatments that you're on, how they're treating you and how the cadence of your day is working. And then we come up with a medical plan to try to smooth it out and fill in the gaps that are holding you back. And then we pair that by connecting you with good physical occupational speech therapy. Everybody needs some degree of therapy with this to keep them going. We have a long talk about all the things you can do to make you better, including exercise, sleep, diet, what makes you happy, and how do we get you doing it? And if there are ever any limits, we come up with a plan to try to address it. And then if there are other issues at play, like sleep issues or headaches or something else, we get you in touch with the centers we work with. We're the captain of the ship and try to navigate your health life in a way that leads you to a path of doing better. But the important thing too is we're a center that prides ourselves on being accessible. We have specialists, I'm telling you, 5 of them, and we have specialists like me who go to Alexandria, Fairfax, Fair Oaks. We have an office in Gainesville. And this fall, we're going to have a specialist 5 days a week in Loudoun County. And our goal for next year is then to put someone south of town in the Springfield area or further down, because you have to be able to see us easily. And we understand travel is a challenge. We also do tons of telehealth, so we can always visit you in your living room if you really want. It's fun. We do it all the time. But the important thing is in between, we have to communicate. We have gotten a reputation as a group here locally of just being insanely accessible, for good, bad, or otherwise. You message us, we will get back to you. You have a problem, you reach out through Sonia, you reach out through us. It's shocking to a lot of people how quickly you'll hear back from us with anything. Because in reality, we're really not living up to that mission if we're telling you to come back in 3 months and good luck, right? We have to communicate in between. We have to be there for you on your journey with this. Then that's how you're going to do your best from here on out. And so to that, I did want to celebrate Sonia Gao, who's sitting in the room right now and is going to probably start blushing. She's our incredible community care coordinator. She's insanely good at what she does. Her email and phone number are in the chat. I'm sure she will now send it back in there again. She is the, we'll send it one more time. She is the everything for our center and the bridge between you guys and us. You ever need anything in the world of Parkinson's, whether you see us or not, email or call Sonia and she will move mountains. I tell patients every day, just email Sonia and she'll send you more info than you ever thought you knew or needed. And then you read it and you're like, this is exactly what I needed. So for anyone out there who's looking for a medical home, reach out to us, come see us. I would put $1 on the table. You won't be disappointed.
I love it. Perfect timing. And again, thank you, Dr. Falconer, but really thank you to another amazing audience. The engagement that you all have with our speakers is just phenomenal. And you're the star of the show because it drives the discussions from what we as providers and speakers think you need to know to what you really want to know. And I hope that this was helpful. And again, I know that this medical practice has changed my family's life. So I know that if Parkinson's or movement disorder is something you're concerned about, they can change your life too. So thanks again, Dr. Falconer and Sonia, for putting this together. And we'll look forward to seeing you at the next one.
Thank you, Steve. Thank you, everybody. Go enjoy the day.